Fractures. This is Musculoskeletal Part 3. And this begins on page 739 in your Mid-Surg book. And you have a wonderful picture at the top of 739 where you have different types of fractures, and you have a box, 32.1 types of fractures. I would look through both of those before testing, okay? Top of 739. All right, so fractures, we are going to either have a complete fracture where you're going to end up after the injury or trauma with two separate pieces of bone, or an incomplete fracture that does not divide into two pieces, a displaced fracture which is out of alignment, or an open fracture which will cause a break in the skin. You see the bone protruding from the skin, and it can cause an infection, or it many times involves nerves and nerve damage also. After the break in the bone or fracture, the body starts to repair the injury within 48 to 72 hours, and it's called bone remodeling. And for this process to completely finish, it can take 1 year to complete bone remodeling. Sometimes fractures can be pathological, which means they're from a disease like osteoporosis. Signs and symptoms of a fracture could be pain, tenderness, decreased range of motion, limb rotation, a deformity of the limb or shortening of the limb. A complete fracture will shorten the length of a limb. If you're looking at someone's legs side by side and one of them has a fracture, obviously the one with the fracture is going to look shorter. Obviously it can cause swelling and bruising, and it may take a few days for the bruising to show. Loss of function also, and physical exam. You can look at a person's limbs to decide about what kind of damage they have. An x-ray needs to be done. You have your different types of fractures that I pointed out at the top of page 739. And I will make note, when you read through these types of fractures, a spiral fracture is associated with child abuse. That may pop up again in our PowerPoint here. And we see some more definitions here about pathological fractures due to disease processes on the left, longitudinal fractures, picture of a spiral fracture, green stick, simple, compound, oblique, comminuted is the way you say that word, where there's fragments of bone there, and transverse, where it is going across the width of the bone there. Okay, and of course, as we mentioned, an x-ray needs to be done to diagnose the fracture, possibly a CT scan of the pelvis if you're not sure about if someone has fractured a hip, to diagnose that. And we'll see this come up a couple of times in your PowerPoint, but you want to splint it as it lies. So you don't want to move it around too much. If someone sustains a fracture or possibility of a fracture in front of you, try to limit the movement and just splint it best you can how it lies. As far as laboratory values, you may see an increased sedimentation rate if someone has a fracture, or a decreased hemoglobin and hematocrit from bleeding. As far as fractures, trauma is the most common reason for a fracture. Bone degeneration or osteoporosis, decreased bone mass, can be a condition that causes a fracture also. Also, when you're looking at someone who you think possibly has had a fracture, look at the mechanism of injury. So let's say that Miss Pam goes roller skating with her great nieces and nephews. I would not try that anymore, to tell you the truth, but let's say I did and I fall, I don't have on any protective gear, and I break my fall with my hand on the ground. More than likely what is going to happen, because of the mechanism of the injury, it's going to give you a clue that Miss Pam has probably broken her ulna or her radius. And that is going to also interfere with the blood supply. I may have a muscle injury because of that also. So that's what it means by mechanism of injury. Also, something to keep in mind, you know, osteoporosis we talked about with chapter 31, but people who have taken protein pump inhibitors to decrease stomach acid for over a year, and an example of that would be omeprazole or Prilosec. They can be more at risk for fractures, or someone who has heavy caffeine use can be at more risk. It really just causes a demineralization of the bone, and plus if the person is drinking too much caffeine, then they are not getting enough calcium in their diet, more than likely. I have been you know, someone who has done this in years past. I'm trying to be better about it. And to help me out, sometimes I'll go get me one of these deliciousness, you know, instead of drinking caffeine. Okay, let's look at treatment of a fracture. Okay, let's say someone is injured in front of you and, oh my goodness, you think they might have a fracture. What am I going to do? I need to provide some emergency care. Oops, I think I skipped something. I'm sorry. Older care patients. Well, just wanted to mention they do have failing vision, lessened agility, alteration in balance. Yeah, let's talk about this for just a second first. I'm sorry. Decreased muscle tone. So that's going to put them at more risk for fractures. Medications that they take. We've looked at all kinds of medications that can cause orthostatic hypotension. A patient who's taking an antidepressant can cause them to be at more at risk for a fall and a fracture. I just mentioned these proton pump inhibitors. And in studies, the risk was highest for people older than age 50 who had used PPIs for more than 1 year. Nexium is another example. I mentioned Prilosec and Protonix also. Okay, so now let's look at someone falls in front of you. You think they have a fracture. You're not sure. So you're just going to treat them as well as you can there. So certainly you want to control bleeding if they have bleeding that's obvious. So clean cloth as you can find and just lightly cover the area to control bleeding. Of course, you don't want to damage the limb any further, but if they have a hemorrhage, they're going to bleed out. So you do have to control the bleeding best you can. Personally, if I have someone who has an open fracture and they are, or compound fracture, and they're in front of me, I'm going to probably call 911 because I'm going to be scared about nerve damage, hemorrhage, you know, before I can get them to emergency care myself. You need to ask the person about their last tetanus immunization. Hopefully it's been within the past 10 years. And when they are in the ER, they may be given prophylactic antibiotics to prevent any infection. Primary aim of treatment, establish the union between the broken ends to restore bone continuity. And we've got our 5 stages of bone healing and repair: blood oozing from the torn blood vessels, forming a hematoma, 1 to 3 days. Other tissue cells enter the clot, granulation tissue is formed, gradually becomes firm, forms a bridge between the 2 ends of a broken bone. 3 days to 2 weeks. Young bone enters the area and forms a tissue called callus, and the broken bone is beginning to knit together 2 to 6 weeks. And the immature bone cells are gradually replaced by mature bone cells. Tissue takes on the characteristics of a typical bone structure 3 weeks to 6 months. Bone is reabsorbed and deposited depending on the lines of stress. 6 weeks to, like I said before, it can take 1 year for this remodeling to occur. And as far as reduction of fractures, and when I use the word reduction, that really just means you're bringing 2 fragments into alignment. So you have 2 pieces of bone, you need to get them aligned again. You may have been through this with a child. Thank goodness I have never dealt with this with my children. I cannot believe, but they have had all kinds of sprains. But, well, I take that back. We've had a fracture in a hand and a foot. I forgot about that. But no long bone fractures, which when I say a long bone, that's typically, like I said before to you guys, the femur or the humerus. Those are examples of long bones. Okay, so a closed reduction, you're bringing the 2 ends of bone together with no surgery. Open reduction, you're going to have an incision and they're going to be realigned, and this is both under anesthesia. And then we also have stabilization, internal fixation, external fixation, cast, splints, braces, or traction. And internal fixation, we have pins, nails, or metal plates. Open reduction and internal fixation. This may be if someone has been in a car accident or had a trauma, or maybe they just broke their hip and they need to have this done. A prosthetic hip joint may be replaced, and autotransfusion could occur. If you've never seen this before, the first time I saw it, I was like, what the heck is going on? But when someone had a hip replacement surgery, the drainage is coming out, and it's coming into a bag that kind of looks like a Foley catheter bag, but smaller. And then it's going through a filter, back into a catheter, and it is going in with the IV fluid and giving the patient a blood transfusion of their own drainage. So it's amazing that can happen. But also IV antibiotics are used for risk of infection. So nursing care, maintain good alignment, prevent complications of immobility, and control pain. You've got these pictures in your book, I think. These are just examples of internal fixation. You will not be asked questions about that on a test. External fixation could be from massive open fractures with extensive soft tissue damage like an accident or some kind of major severe trauma, infected fractures that don't heal properly, or multiple trauma. This is a picture of an external fixation. They're going to be no weight bearing, months to years of therapy. And nursing management, and if you will, write this down on your PowerPoint and highlight it. Okay, I've seen this on a HESI or NCLEX before, but pin site care, how do you take care of the pin sites, nursing management of that. Okay, so you will have applicators to use for clearing drainage away. Underline applicators, and you only use them once. Okay. And the external fixation is uncommon, and if you see the word ORIF, that is an open reduction and internal fixation. So if you see someone with hip ORIF, they're going to have open reduction and internal fixation of a hip fracture. Okay, cast materials include plaster and synthetic cast, short leg cast, long leg cast, slings, and spica cast. I don't think we have a PowerPoint about a spica cast. Just look that up in your book. You may see a question about that, which is covering the entire pelvis area. So be sure and read through that also. So a cast is going to immobilize the injured body part. And a synthetic limb cast is lightweight, it dries quickly, and they can bear weight within 30 minutes. It's always going to be under doctor's orders, but typically they can bear weight within 30 minutes. A plaster cast takes 48 hours to dry, 48 to 72 actually, and you have to keep it dry to prevent infection, and if the cast does get wet, has to be changed as soon as possible. So let's say it's on Saturday evening and your child has a cast and you took them to an event of some sort and they accidentally got in a swimming pool. They're going to have to go into the ER and get that repaired because their bone is healing. So if the cast gets wet, then the ends of bone are, not going to be healing properly anymore. So braces and splints. There's such thing as a fracture boot, hinged brace, slab brace also. Patient teaching, explaining the procedure, when it's going to be placed. Also, if a cast is going to be placed, it will feel warm as the cast sets and dries. And you're not supposed to ever put fresh cast on plastic. That will ruin it possibly. And never cover a fresh plaster cast with a blanket. Braces may have adjustable dials. And braces are great because they can be easily removed, but it may not be the appropriate therapy for what someone needs for their injury. But this is just a couple examples of a walking boot. And just a brief review of traction or explanation of skeletal traction. It is pins, wires, or tongs directly through the bone at a point distal to the fracture so that the force or pull from the weights is exerted directly on the bone. That's what skeletal traction is. So just kind of get that definition in your mind and think about a skeletal traction using 10 or more pounds of weight, and the body acts as the counter traction. Underline that. The body acts as the counter traction. So the mechanical pull extends and holds. And we'll look at some different types of traction here in a second. A bandage or moleskin or foam traction boot is applied to the limb below the site of the fracture for a skin traction, and then a pull is exerted on the limb. No more than 7 to 10 pounds of weight is used for a skin traction, and it can be continuous or intermittent. And you see skin traction or bucks traction over on the left-hand side here. Okay. And in the middle here, you see what's called Russell's traction. And over on the right, halter traction, which is relieving pressure on disc, and it is rare. And just add a note in there about if someone is going to have a reduction surgery, sometimes they are given medication for pain or spasms preoperatively because they can be very common. We also have pictures here of pelvic traction and balanced suspension traction. Okay, so what might you be asked on a test? Either test in our class, HESI test, NCLEX test. Traction devices must be assessed to see that they are in the correct position and that the weights are hanging free. Underline, the weights are hanging free. And they're not on the ground, okay? The patient's body position should be assessed for proper alignment. And remember I said the body is the counteraction. Complications of fractures. The sooner a fracture is fixed, the less likely the chance for complications. Healing can be impeded by improper alignment and inadequate immobilization. Continued twisting, shearing, and abnormal stresses prohibit a strong bony union. Open comminuted fractures and surgery. They can be more at risk for an infection with this type of fracture. Antibiotics are given to prevent infection. Inadequate calcium and phosphorus, vitamin deficiency, and atherosclerosis are going to delay healing. Monitor temperature, white blood cell count, the appearance of the wound for redness, swelling, heat, and drainage, and administer IV antibiotics. For an open reduction surgery, they really need to be started within 6 hours on their first dose of antibiotics. One that's frequently used is ANCEF. ANCEF. ANCEF, frequently used, and it's also called cefzolin. Okay, I wanted to mention a couple of things before I close out this part 3. Cast checks. All right, if someone has a cast, and let's say you're taking care of them after it's applied, you need to be doing neuro checks on the extremity every 1 to 2 hours, and then 4 times a day, and PRN. So have them wiggle the fingers or wiggle the toes that are exposed. If you're helping them move, palm the cast instead of using your fingers to lift it. I think there's a picture of that in your book. It's warm while drying, and that's common. We talked about that. Don't put plastic on it or a blanket on it while it's drying. Monitor for infection. The edges of the cast may be covered in gauze if they're irritating to the patient. And if someone has an open reduction with internal fixation of the hip, I wanted to talk about a few complications. Okay, when you talk about this patient, they're typically an older individual, middle-aged or older individual. So they're going to be a little bit more at risk for DVT anyway, and the immobility from the hip surgery, and this could even be with knee replacement surgery, rotator cuff surgery, any surgery that makes someone more immobile. You need to think about DVT, deep vein thrombosis prevention. I wish we were in class so we could talk about this, because I know you already know a lot about this, so you could spit this back to me, I'm sure. But DVT prevention, you are going to monitor them for any shortness of breath, difficulty breathing. If they're on monitors, obviously you're watching their oxygen saturation. And you have to think about your patient prior to the surgery. Were they a smoker? Were they in good health? Have they had a previous blood clot? Things like that. Would you want someone to take aspirin prior to an open reduction surgery or hip surgery, or no? They're going to withhold medications that contain aspirin if possible. Now, certainly if it's an emergency situation, they may have taken it and need to be monitored, but so DVT prevention is important. Monitor for shortness of breath. They do need to go to their physical therapy appointments, follow their doctor's orders about being mobile after the surgery, so they don't need to lay around. If the doctor sends them home with instructions to be up 4 times a day, and as they can tolerate, then they need to do that. Skin integrity needs to be monitored with the patient that have had a musculoskeletal surgery of any kind. Monitor the pin drainage, okay? Just like with any other open site, you're going to monitor it to make sure that you don't see crusting, purulent drainage. We talked about not reusing an applicator tip for cleaning, but you do want to keep it clean and clean any crusting. And when you're cleaning a wound, you want to clean from the inside to the outside. Monitor your patient for increased temperature, increased pulse. Those are signs of infection. Okay. We do not want to put a coat hanger down a cast and scratch, certainly. Okay. All right. I guess we will stop here. Patients certainly may need analgesics for pain control, and certainly we are doing our circulation checks just like we mentioned. Patients may, if they're older, let's say they're in their 50s, 60s, they may go home with some Lovenox therapy or Xarelto or something like that to prevent blood clots. If they have had a long bone fracture or hip replacement or something like that. I would also like for you to find in your book and read through compartment syndrome, okay? Sometimes if someone has a musculoskeletal surgery with some pretty severe swelling, there's nowhere from the swelling to go, and so they could have this life-threatening crisis that occurs called compartment syndrome. Many years ago, we had a patient at our hospital that was in her 20s, and she had to have an amputation because of compartment syndrome. So severe increasing pain is not normal. So remember when I mentioned if someone has a cast, a splint on their body, something like that, their pain should improve every day, all right? If their pain is increasing, that's not a good sign. If they are sent home with a prescription for Percocet, and they can take 1 to 2 Percocet every 4 to 6 hours, and that's not helping them, they need to call their doctor. They need to get checked, because it could be that they have compartment syndrome, and they have to do something called bivalving the cast to cut an area to relieve. And so just wanted to mention that as well. Okay, so I think that finishes up fractures. When we start back, we'll start back with osteomyelitis with our next YouTube lecture, and talk about rheumatoid arthritis, osteoarthritis also, and